In this presentation, we will discuss infectious mononucleosis, and then in the second part, we will talk about the Epstein-Barr virus. This presentation is made for medical students and junior doctors who are not specializing in microbiology or infectious diseases. If you want a more detailed description and a transcript of this presentation, you will find a link below this video to the microregistrar.com page on infectious mononucleosis. The most important cause of infectious mononucleosis is the Epstein-Barr virus. It belongs to the herpes virus family, which includes herpes simplex virus, varicella-zoster virus, which causes chickenpox, cytomegalovirus, and human herpes viruses 6, 7, and 8. Human herpes virus 8 is also called Kaposi sarcoma virus, as it causes Kaposi sarcoma in patients infected with HIV. You may want to remember that cytomegalovirus may also cause a mononucleosis-like syndrome. Infectious mononucleosis is a disease of children, teenagers, and young adults. It is usually seen when we get the infection for the first time, which is called the primary EBV. However, EBV infections in children are often mild and even asymptomatic. We can see symptomatic disease mostly in teenagers and young adults. The primary EBV is rare in adults, but if it happens, it usually presents with severe symptoms. How is EBV transmitted? EBV is mainly transmitted via contact with infected body fluid. The commonest model is saliva. After infection, the patient may shed the virus in their saliva for up to 6 months. It has also been seen that an infected person may shed EBV intermittently throughout their life. It is called kissing disease, but EBV may transmit via much less intimate contact. EBV can also be transmitted via sexual contact and breastfeeding. What are the signs and symptoms of infectious mononucleosis? Infectious mononucleosis presents with a triad of fever, tonsillar pharyngitis, and cervical lymphadenopathy. In some atypical cases, pharyngitis could be absent. Other common features are fatigue, splenomegaly, and low mood. Fatigue is a common symptom and often helps with diagnosis. You may also find headaches, body aches, hepatomegaly, and rash. Although most cases resolve spontaneously, some of the infection mononucleosis can lead to complications. It may affect almost any organ. It may help if you try to remember like this. 1. CNS complications, which will have most names. 2. Hematological, and 3. Other organs. CNS complications are inflammation in the brain and meninges, that is meningoencephalitis, the spinal cord, that is transverse myelitis, and optic nerve, optic neuritis. It also causes cranial nerve palsy and Guillain-Barré syndrome. Hematological complications are anemia and thrombocytopenia. Amongst other organs, the most important perhaps is splenomegaly, which may result in splenic rupture. You may need to ask a patient not to involve in sports for 4 weeks to avoid this. It can also cause inflammation of the heart, airway, liver, and kidney. You may also find headaches, body aches, hepatomegaly, and rash. The clinical features in a typical age group should raise the suspicion of mononucleosis. It becomes problematic when the distinctive features are absent. The blood test should show an increase in white cell count. If you do a blood film, you may see atypical lymphocytes. However, you must remember that it could be seen in many other diseases and viral infections. Anemia and thrombocytopenia could also be present. The heterophile antibody test is a quick test that can be used to test for mononucleosis. Examples of this test are the Paul-Bunel test or the monospot test. It is a useful test but can be false positive or false negative. You should not perform it in immunocompromised patients or children below 4 years old. EBV serology is preferred for diagnosing acute infections like mononucleosis. However, if it is inconclusive, or in an immunocompromised patient, you may need to perform an EBV PCR. What are the differential diagnoses? Streptococcal throat infection. Group A Streptococcus or Streptococcus pyogenes is the commonest cause of strep throat. This bacteria is sensitive to penicillin and amoxicillin. However, you should avoid giving amoxicillin if you have not excluded infectious mononucleosis. Amoxicillin, if given to patients with infectious mononucleosis, may precipitate a severe generalized rash. Some infections may present with mononucleosis-like symptoms. These are CMV, HIV during seroconversion, toxoplasma infection, viral hepatitis, and adenovirus infection. Similar symptoms can also be seen in non-infectious diseases, like leukemia and with certain drugs, for example, phenytoin. Treatment. Infectious mononucleosis is usually self-limiting. Supporting treatment line providing nutrition, hydration and pain relief in the form of paracetamol or NSAIDs are sufficient. The role of steroids and acyclovir is controversial. It can be used in selected cases only. Avoid sports for 4 weeks as there is a risk of splenic rupture. That finishes the infectious mononucleosis. Now we are going to discuss the Epstein-Barr virus for a few minutes. Epstein-Barr virus belongs to the herpes virus family, which is an enveloped DNA virus. EBV is ubiquitous in nature. Most people are infected by adulthood. It has been seen that 95% of healthy individuals are infected. The virus uses a receptor called CD21 to enter the cell they infect. It infects RB lymphocytes and a few other types of cells. Once infected, the virus may take one of the 2 routes. It may start an infection, or it may go into a dormant phase called the latent phase. In the latent phase they ensure that the B cell never dies, or in another word, immortalize them. Once they go into the latent phase, they may occasionally reactivate to cause infection. What diseases does EBV cause? The commonest infection is mononucleosis, which we have already discussed. It is also associated with multiple malignancies, mainly lymphomas, for example, Burkitt's lymphoma. Other malignancies are nasopharyngeal carcinoma and leiomyoma. Other infections associated with EBV are oral hairy leukoplakia, chronic EBV infection and lymphoproliferative disorders. Diagnosis of EBV infection involves clinical review aided by serology, and PCR when required. PCR is useful if the patient is immunocompromised, as serology could be unreliable. Blood tests, blood films and imaging also helps in our diagnosis. Treatment of EBV infection is mostly symptomatic. Pain control can be achieved by paracetamol, acetaminophen or NSAIDs. The role of steroids and acyclovir is controversial, but a small benefit can be achieved in a select group of patients. A specialist opinion should be sought. A vaccine for EBV is being developed. Thank you for listening. You will be able to find the transcript on the microregistrar.com.